I appreciate the invitation to talk about this subject. I've never given this talk before, so I guess the question is how I refuse admission to the patient who will not benefit, and I thought I would think about how I do things, and I thought I'd look through the literature. And usually when you're giving a talk, the first place to start is usually a dictionary. So the question is, how do we define benefit? And looking at my old dictionary I don't use anymore, I just go online now. So something that promotes or enhances well-being, to help someone, to aid someone, an act of kindness. So the question is, do we, when we talk about ICU benefit, talk about benefit in those terms, and perhaps not. So let's look at some august bodies and how they have decided we should use our scarce resources. So the AMA several years ago looked at, number one, the likelihood of benefit for the patient. So that's benefit. Impact of treatment in improving quality of life, duration of benefit, urgency of the patient's condition, amount of resources required for successful treatment. Unfortunately, the indications for ICU admission and discharge are poorly defined. The identification of patients who benefit, however we define it, is rather difficult. And there's an urgent need for appropriate ICU admission and discharge criteria. And if we look at some consensus statements, the ESICM Ethics Committee in a consensus statement in JAMA stated that the priority patients should be given to those most likely to benefit from the ICU. And another consensus task force stated that this should exclude patients who are too well or too sick. The ones sort of in between are the ones who could probably benefit most. But how should we define benefit? Should it be ICU, hospital, or one-year survival? Should it be a good quality of life? Or perhaps should it be the cost for that outcome? And who should determine benefit? We, I guess as physicians, think it's typically the physician who knows best, but perhaps it's not only the patient, or the physician, maybe could be the patient, the family, and others have suggested the nurse, the judge, or perhaps society should decide. So again, this consensus statement published in JAMA looked at factors important in determining benefit: the likelihood of a successful outcome, the patient's life expectancy, anticipated quality of life of the patient, wishes of the patient or the surrogate, burdens of those affected, the health and other needs of the community and individual, and institutional and moral and religious values. Now, many physicians don't use the term benefit. They say, well, this is futile therapy and we should not provide this for the patient, substituting perhaps the word benefit. But how do we define futility? So different authors have defined it differently. Schneiderman looked at a group of different studies, and one method was the last 100 cases, the medical treatment did not work. Preserving permanent unconsciousness would be considered futility, and continued dependence on intensive care would be another definition for futility. But Bob Truog, in a paper in the New England Journal of Medicine, suggested that we should be talking about objective methods, and we should use the term futility only when we have physiological futility. And what is physiological futility? If we're ventilating a patient and we cannot maintain adequate ventilation and oxygenation, if the patient's on 100%, 20 at beep, the PO2 is still 30, the CO2 is 120, despite everything we're doing, we're not really ventilating that patient. The patient who's undergoing CPR, the patient has a perforated ventricle, and every time we pump, the blood just sort of comes out of the ventricle. Well, that's going to be futile, and that's probably where Futilus was coming up the mountain with his bucket of water and the holes in it, and he never got to the top of the mountain, had to go back down and keep coming up. So that's probably when we should use the term futility, but in medicine, it's rather unusual that we have physiological futility. And Tom Prendergast has made the statement that different interventions look very, very different in terms of futility or benefit when they're cheap, easy, and without morbidity versus those that are expensive, technologically intensive, and cause great pain and suffering. And treatments are futile only when they will not accomplish their intended goal, and then the question is, whose goal? That of the physician, the patient, or the family? So in general, I believe that futility is a subjective term that doctors sometimes use to objectify things, to justify or excuse the course of action they want to take. And in general, it should be avoided unless we're talking about physiological futility. And we should talk more about objective medical facts in terms of prognosis, probability, goals of therapy, the various value systems of the physicians and patients, and these can be more helpful in making the decisions. So another group put together stated that treatments that are unlikely to be beneficial, are extremely costly, and are of uncertain benefit should be considered perhaps inappropriate or inadvisable, but they should not be labeled as futile. And Tom Lantis has said that refusal of giving a therapy is more difficult when a patient's life is at stake. And since we as intensivists believe that we're improving survival by putting our patients in the ICU, when the chance of success is low but the alternative is death, and the patient desires this therapy, the presumption should be in favor of treatment, or in this case, ICU admission, assuming you have a bed. And in fact, the current practice is that we do accept various requests for futile therapy, and our ICU admission and is full of patients who have little chance of survival. Here's a paper from Marian Danis several years ago looking at the fact that patients in families, patients in the ICU, would want to continue in an ICU after they were discharged to go through this all again, even if they only had a few weeks to survive in the ICU. And Jean-Louis Vincent and others have shown that we physicians typically admit many, many patients who have no hope of surviving. And let's look at different diagnoses. When we decide to treat a patient, admit a patient to the ICU, here's one study looking at the inequitability of doing CPR. It's more common for physicians to make a patient a DNR if they have AIDS or cancer, but even if they have the same prognosis and the same mortality with cirrhosis or CHF, those patients are not made a DNR as quickly. So we, even with objective information, use our subjectivity in making life and death decisions. And when we look at various studies in terms of how did people decide to withhold or withdraw in the Ethica study, unresponsive to therapy, if the vasopressor is not working, if the ventilation is not working, that's a pretty good medical reason. But many times it's a neurological reason. What kind of quality of life is that? We're making decisions at the end of life, or chronic diseases, because those patients with cancer or multi-organ system failure may not benefit. And in fact, when you look at various studies, many, many studies have looked at the reasons for rejections of patients to the ICU, and among others, admission diagnosis, diagnostic groups, and underlying diseases are the typical reasons why we're rejecting patients, because those patients, as we define them, cannot benefit. So again, looking at the definition of benefit, I would dare say that our definition of benefit from the ICU is not exactly the one we see in the dictionary. And I think it's important, and I've portrayed for you some of the subjectivity in some of our decisions to admit patients to the ICU, also in terms of foregoing life-sustaining treatment. And some of these decisions, and here was something related to foregoing life-sustaining treatments, are not just medical decisions. Some of them are ethical decisions. Sometimes it's based on uncertainty, soft data, and many times doctors disagree about the prognosis, and perhaps it's not objective medical decisions we're making, and sometimes the value judgments of the patients or families can be just as important. And here's one study looking at differences between the primary attending and the ICU attending. Here, the primary attending, the primary care physician, felt that 100% of these 85 patients would survive, whereas the ICU attending thought less than 80% in 23, 80 to 95% in 46. Here, the primary attending thought 100% mortality in 8 patients, the ICU attending greater or equal to 20%, and here, the primary attending, 1 patient, 80% survival, and the ICU attending thought the opposite, that patient was going to die. So we have differences of opinion on the same patient of what the prognosis is.